Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clivax. Thank you for joining me in my latest video using the iClearScope endoscope, and I just want to start off by thanking everyone for their really kind complimentary words on yesterday's video, which has prompted me to do another video with me live on the narration. So here we have a really interesting case. It's of a patient who attended with otitis externa. So otitis externa is an umbrella term given to an infection or inflammation of the outer ear. Now the outer ear consists of the pinna, or it's also called the auricle, the ear canal itself, so the acoustic tube, and the outermost layer of the eardrum. So the eardrum is actually 3-ply thick. You've got the outer layer, which is lined with the same skin that lines the ear canal, the epithelial layer of skin at least, the outermost layer. The middle layer of the eardrum is made up of fibrous tissue, and the most medial layer, so the inner layer, is made up of mucosal skin cells. So mucosal skin cells are similar to the skin that lines the inside of our nose and our mouth, so it's more secretory. So if you have an infection or inflammation of the pinna, the auricle, the acoustic tube, also known as external auditory meatus, or the outermost layer of the eardrum, we call that otitis externa. If you've got an infection of the middle ear, we call that otitis media. And if you've got an inner ear infection, which affects the cochlea, so the organ of hearing, and or also including the auditory nerve, or you can label that as otitis interna, but it's not a phrase that we typically use for an inner ear infection. I think we just call it an inner ear infection normally. Now, presenting here is just squams of dead skin. And what I mean by squams of dead skin, if the skin was fully shed, so if it was completely off the canal wall and the individual skin cells are separated from one another, we call that desquamous or desquamous. But when the individual skin cells are still interlocked, which they are here, because you can see you've got chains almost, layers of skin, and it's not fully off the canal wall because this is still semi-adherent. We call this, I would myself call this squams as opposed to desquamous. And it's quite typical with a fungal infection actually. Now, I'm not 100% sure if this is bacterial or fungal. So I have written to the patient's GP post-procedure, and I've requested that they have an ear swab taken to confirm the presence of either a bacterial or fungal, or indeed both, prior to them being prescribed medication, because if this indeed is a fungal infection and they are prescribed antibiotics, it's actually going to make the fungal infection worse, because what the antibiotics do, not only do they inhibit or indeed kill the pathogenic bacteria, but it will also kill any healthy bacteria in the ear, which will then allow the fungus to further reproduce because it's got no competition. So remember, our ear canals, it's not a non-sterile part of the body. There is natural skin flora, and habitating on this skin is an ecosystem of bacteria and fungi. So when you've got no bacteria, the fungi has got no competition, so it then allows the fungus to kind of colonize and further reproduce until it becomes pathogenic. So we need to really ensure that they do receive the appropriate medication. Now, this patient, admittedly in the past, has used a Q-tip, what we call in the UK a cotton bud, and they have also admitted in the past to getting water in the ear, but they have reassured me on this occasion they haven't. They've listened to my previous advice and have been very careful not to poke in the ear. Now, they do have an urge, a tendency of wanting to scratch inside the ear, and that's because the ear is extremely itchy and irritable. Just by looking at this, you can understand why. But I know it's easier said than done. We all have that urge to scratch and itch, but by scratching this, it's going to make it worse for two reasons really. First of all, when you scratch the ear, you're going to abrase the surface layer of skin, and when you do that, you're going to allow the bacteria and fungi to further penetrate into the deeper layers of skin, but also when you abrade the outer layer of skin, that skin is going to have to re-heal, and that re-healing process is actually itchy. So by giving yourself short-term relief of an itch by scratching your ear, you're actually in the long term, probably a few weeks in the future, almost guaranteeing yourself a secondary itch as a result of you itching or scratching your ear. So if you do have itchy ears, do go and see your GP, your audiologist, or your ENT. There's different things that can be done. Now, itchiness can be caused by skin conditions like eczema or psoriasis, but it could also be caused by Otitis externa. It could also be caused by earwax. So do have your ears examined. And the last thing we want to do for you to do is to poke around in your ears. I did a video last week, I think, with the 10 most bizarre foreign bodies that I've extracted from people's ears, and I would say at least half of those cases is when patients were experiencing itchy ears and they used some sort of instrument, if you want to call it that may be lying around the house. So I had a TP dental floss brush that got trapped in the ear, a pen cap, for example. So you are putting yourself at risk of serious damage. And remember, the ear canal itself, it's only 2.6 centimeters on average in an adult in length. So the eardrum is not too far away. So you do got to be really, really cautious and just resist the urge of poking inside your ears. And there is medications that can help. Some people use, and I think it's possibly a good thing depending upon the root cause, but some people, especially as you get older, so our ears produce natural sweats, oily sweats, and they're secreted by ceremunous glands, which are modified sweat glands. So the modified sweat glands, they produce a different type of sweat. It's not like the sweat you found on your brow, which is mainly water and salts. This sweat is more oily, it's got more lipids, it's got more proteins, and it normally is secreted during the flight or fight response. So unlike the sweat we have on our brow, that helps us to regulate our body temperature. So the body produces these sweats and they form into kind of a bubble, if you like. And in order for that sweat to evaporate, it absorbs heat from the body and it causes that little sweat particle to evaporate. The sweat produced in the ear has got nothing to do with thermoregulation of the body. And it's primarily secreted when we're somehow emotionally under distress. Sometimes also by poking in the ear, you have this emotional sweat at the follicle of the hairs, but also in the dermis layer, which is the second layer of skin. And just by applying pressure, you almost, we call it mechanical milking, you're squeezing out this oily sweat into the ear canal, which eventually forms into earwax because it mixes with dead skin cells in the ear, and also it mixes and amalgamates with sebum. So sebum is an oily lipid secretion. They are secreted by the sebaceous glands. And most of the hairs on our body at the hair follicle have a sebaceous gland connected. Sometimes you can have two. And the function of sebum is to provide some acidity. So again, the acidity is really, really important in the ear. So when our ears are mildly acidic, they allow non-pathogenic bacteria to harmlessly live in there. But if the pH level of the ear increases and becomes more neutral or alkaline, it allows more pathogenic bacteria to colonize and reproduce and then cause an infection of the ear. But also sebum is a natural moisturizer. It helps to moisturize the skin. Now, as we get older, the sebaceous glands, the ceremunous glands, they kind of shrink and shrivel, so they produce less sebum, they produce less emotional sweat. So your ear becomes drier, so the skin hasn't got its natural moisturizer. So age itself can cause itchiness of the ear. So if that's the case, I would recommend using some medical grade olive oil, and that's almost an artificial substitute for the natural oils that we should be producing but you no longer are. Now, it's important to use medical grade olive oil, and the reason for that is that it's cold pressed, so there's no heat involved. And if you introduce heat into the oil, it kills away an important antioxidant called polyphenol. And polyphenols help to kill free radicals. So every cell, it has its metabolic activity, and one of the byproducts of that is that it produces free radicals. Now, free radicals, if you think about the atom, the molecule, it has an incomplete outer ring of electrons, so it's searching for an electron to complete its outer ring. And as a result, it's highly volatile and reactive, and it can start killing away adjacent tissues and other molecules and organelles in the ear to kind of capture that missing electron. So what polyphenols do, they donate electron to that free radical, so it becomes less volatile. Because if you have an excess of free radicals in the ear, you can get necrosis, you can get a decaying of tissue of all sorts. So medical grade olive oil, for that reason, is very good. And because it's got a higher level of polyphenols, it's got a longer shelf life. So there's less impurities, less bacteria or fungi that may have colonized the oil itself. So you can use that once a week if you like. The way you use it, you tilt the ear that you want to put it in so it's facing the ceiling. A couple of squirts, so I would recommend getting a spray, it's far more easier to apply. A couple of squirts, let it sit there for a few minutes, and the important thing is then to come back the other way, let it drain. If you don't let it drain, the oil's just going to coagulate very deep in your ear, and it may then not come out, and then you'll have to get your ears cleaned with the oil, of the oil. And that will just help moisturize the skin. But in more extreme cases, you will possibly need some antibiotics or antifungal treatment as well. Avoid water. Water is possibly one of the main causes of dry ears, and you may not think that at first, because you think, well, water will help hydrate the skin. Now, how water works in the ear. Now, if you've got warm water, what warm water will do in your ear, it will kind of wash away, it will kind of flush away these natural oils and sweats that our ears produce. And when you've no longer got these natural oils and sweats that's moisturizing the skin in your ear, the underlying skin is no longer protected, and it over-absorbs water. And when it over-absorbs water, these skin cells are actually hydrophilic, so they like water. And it causes the skin cell to swell and then burst and then break down, so a maceration of the skin. And when that outer epithelial layer of skin is macerated, the skin becomes dry. Internal water in the deeper layers of skin then rise to the surface, and it evaporates, and it gives you a very dry and cracked skin. Even if you have cold water in your ear, if it's there for a long enough amount of time, again, eventually the skin cells will absorb it and swell, expand, burst at the membrane, become macerated. So water, I do stress it a lot, and it's why I don't perform ear irrigation. I understand a lot of audiologists do, and that's fine, as long as the patient is aware of the risks. In the UK, we've got the National Institute of Clinical Excellence guidelines, and irrigation is regarded as a method of earwax removal. And I understand also some cases, especially if it's really mushy wax on the eardrum, water irrigation would be probably easier to perform to wash that away. But I'm just, for myself, and that's just a personal preference, I try and stay away from water. I've performed irrigation before, but that was just during my training. I actually trained on my ENT colleague, Darius Rajali, and he practiced on myself. So fortunately, I didn't develop an infection afterwards. But what I also notice is we're coming to that time of year where people are going on their summer holidays, or will do. And after the summer, we just have a big influx of people attending with ear infections. And so they're going into dirty pools whilst on holiday, and this dirty water is getting into the ear, and it's leading to infection. And once someone develops swimmer's ear, so we call that swimmer's ear, when water leads to a bacterial infection, they just become more susceptible to developing ear infections in future. It's just anecdotal finding. I'm not saying there probably needs to be some more clinical research, but yeah, once a patient develops an ear infection, so you might have been lucky and never developed an ear infection after getting water in your ear, but that one occasion you may be unlucky, it then just makes you more susceptible in the future to developing an ear infection. So it's just working away, so we can see the eardrum now. Sorry, I've kind of probably talked a lot about the condition of the ear and less about the procedure, but I'll just recap, summarize what we're doing. So I was just peeling away all these multiple layers of dead skin off the canal wall. You can see the skin, it's irritated, it's inflamed, it's slightly swollen. And we've got to be careful, because when it is inflamed and swollen like this, it's a lot more sensitive. So if we catch the skin, we're more likely to cause a laceration and possibly some bleeding and blistering. So just be really, really gentle. I'm using the fine end suction probe. So I've curved the tips, I've bent it slightly so I can get access into that anterior recess. I'm actually holding the endoscope slightly differently for this patient. So I'm holding it more horizontal. If I was to examine this patient's ear with them sat upright like I am right now, you would need to rotate the view that you're getting clockwise by 90 degrees. So although the patient wasn't lying down, the appearance of the eardrum does look like they're lying down with their head back because of the way I was holding the endoscope. I just found it gave me better access in the ear. I think this patient's got a slightly longer ear canal than most people, so using that method, I just had better insertion of both the endoscope and the instrument, which is really, really important. So we're just working more laterally near the entrance now, just peeling away the skin, going towards the eardrum. So the patient did notice a significant improvement in their symptoms, but I stressed to them that if they don't get the appropriate medication and treatment that they need, that this will come back very quickly. So we wrote to the doctor straight away. We sent a copy of the letter to the patient. So once they've got the copy, we encourage them to make contact directly with the GP, as opposed to waiting for the GP surgery to contact them, because by the time they get the letter, they open it, process it, upload it in the system, and a doctor can review it. It might be a week even. So I want this patient to strike while the iron's hot, so to speak. And again, with stress, don't poke in the ear, don't get water in the ear, because it will just make their symptoms worse. So probably halfway in the ear canal, near the top, although it looks like the back part of the ear canal because of the way I've angled the endoscope, it's actually more at the roof of the ear canal there. So again, I'm just mopping up here. This is right near the entrance. This is on the cartilage portion. You can see it's got a bit of spring. So the cartilage portion of the ear canal, the outer third, I'm sorry if you've been watching my videos for a while, you probably already know this, but for anyone new to the channel, the ear canal can be subdivided into thirds. The outer third is made up of cartilage, and the skin that lines the cartilage portion of the ear canal is 1 millimeter thereabouts in thickness, and it has 3 layers. You have the epidermal layer, which is your kind of protective barrier. Underneath that, you've got your dermis layer, and in the dermis layer, you've got collagen, you've got elastin, and you've got the hair follicles, you've got some nerves there. And it's the collagen and elastin which gives the skin its smooth, kind of dense structure. And then underneath that, you've got the hypodermis layer, or the subcutaneous layer, and that's predominantly made up of adipose tissue, so fatty tissue. So it provides a buffer. So when we're working on the outer third of the ear canal, we can, I'm trying to phrase this right, not gung-ho, but we can apply a bit more pressure without it being sensitive to the patient. But if you do apply too much pressure, of course, it will be uncomfortable for the patient. When you enter the inner 2/3 of the ear, that's what I call the danger zone. That's where it's the bony part of the ear. So of course, bone is a lot more rigid in comparison to cartilage. But also importantly, the skin that lines the bony part of the ear canal is just the epidermis layer of skin, that most superficial layer. And the thickness of that is about 0.1 millimeters in thickness. So it's 1/10 of the thickness of the skin that lines the outer third. So therefore, the inner 2/3 of the ear canal, the bony part, is far, far more sensitive. And that's why if you watch any procedure, not only for myself, but or the audiologist, whenever, or nurses or doctors in ENT, whenever they're working on the bony part, they're a lot more careful. If I've had some trauma to my ear canal before on the bony part, so I'm fully aware of how much discomfort, and it's a very acute pain that it can cause a patient. So for that reason, because I've experienced it myself, I want to ensure I don't inflict it on my patients. So I know sometimes I get a few comments that get a move on, but I've always want to put the patient's comfort and needs at the forefront of anything I do, really. The last thing I want to do is cause unnecessary pain to a patient, and well, they're not going to come back to me, are they, as well? So it's not all around, it's not a good thing. So just some residual skin. I could potentially have left this, but I just want to clear as much debris and dead skin as possible. And the reason for that is when this patient does get their medication, it's going to allow the medication to really penetrate on the surface of the skin that's infected. So I'm really pleased with that. I can at least visualize the eardrum. I can see the hammer bone. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.